Can I have your attention, please? We will start this session on time. So it's my great pleasure to introduce Dr. Gobbi today. And how I've decided to introduce her is not by flooding you with incredible statistics on her performance in peer-reviewed journals and grants, but I would like to quickly summarize a remarkable career path. Dr. Gobbi did her medical training and psychiatric training in Italy and had started doing in vivo electrophysiological experiments towards her PhD in Italy, and then joined the unit at McGill University, a neurobiological psychiatry unit, to complete her experimental work, to complete her PhD. And I have to say that when she was in our unit, she was an incredibly skillful electrophysiologist. She was managing to record locus coeruleus norepinephrine neurons in mice that nobody had done before or had achieved in our unit. And then she, of course, continued her clinical work while at McGill, gaining assistant professorship, tenure track, and established her own laboratory and very importantly, her own line of research independently from the McGill unit where she had worked before. She, in particular, worked on the development and the study of melatonin receptors, and it's my understanding that she has a patent for a specific melatonin receptor medication, and as well, starting to work on psychedelic medications, looking at mechanism of action, and then she climbed through the ranks to assistant professorship at McGill, gaining tenure, and as well getting very nice funding from our federal institutes for research in mental health, and was awarded a Canada Research Chair, a Tier 1 Canada Research Chair, which is 7-year support, which is renewable. And this is one of the highest award that scientists can get in Canada. So throughout this career, she has published some really highly cited papers, for example, in PNAS and so on. Quite varied clinical practice. And also, and she'll probably tell you about this, that she was instrumental as well in Quebec to raise the legal age of cannabis purchase from 18 years old to 21-year-old, knowing what some of these products can do to brain development. So perhaps with no further ado, I'd like to invite Dr. Gobbi to give this plenary lecture. And what I've forgotten to say, actually, so several years ago, she was elected by the membership of CINP to be the secretary and be on the executive committee. And now Dr. Gobbi, as we say in North America, has broken the glass ceiling. And we will announce actually officially tomorrow that she will be the next president-elect of CINP. Congratulations, Dr. Gobbi.
Thank you very much, Pierre, for this nice presentation. Actually, Pierre was instrumental to take me from Italy to Canada. It was in 1997. I was in a meeting of biological psychiatry in Nice. I was present in a symposium, a small work abstract, and Pierre was the chair. At the end of the symposium, I asked, could I come to Canada for stay 10 months, 1 year? And now it's a 26th year that I'm in Canada. So thank you, Pierre, for this proposition. Okay, today we talk about cannabis, mood disorder, and the endocannabinoid system. First of all, my conflict of interest. All this research was sponsored by the government of Canada or Quebec or foundation. There is only one part about the cannabidiol that was sponsored by Aurora. And then, very important, this presentation includes off-label drugs. Why I'm so obsessed about cannabis and depression? When I started my career in 2001 or 2002 as a PI, I was observing, especially in Canada, a lot of young patients that were presenting severe depression after long-term cannabis consumption. At this time, Canada was the country with the highest number of adolescents smoking cannabis, and the age of the first cannabis use was 12, 13 years old. So it was like that I started to study the relationship between cannabis and depression in my lab. A lot of work was done in England by Dr. Robin Murray about the link between cannabis and psychosis, but very little about cannabis and depression. Since then, we published more than 30 papers on this topic. Then it happened a little bit unexpected that Canada was the first country to legalize completely cannabis in 2018. So, and I serve as expert witness in the Parliament of Quebec. Quebec is a province of Canada, to increase the legal age of cannabis consumption in 2019. And this law passed with all the consensus of the Parliament. Then in 2022 was also called by the Superior Court of Quebec, because at that time Quebec decided not to advertise for cannabis, but some company went against this law, say that was against the freedom and the chart of Canada. So the Superior Court, the judge asked me to be an expert witness. I have to provide a 160 pages document, but at the end, the law was restated and no advertisement for cannabis in Quebec. So this, I'm very proud to have contributed also this legal aspect of cannabis regulation. So first of all, thank you to all the people that work in my laboratory in these last 20 years. So, but let's start from the real life. I would like to start this talk about one of the 1,000 patients that I saw in the last 20 years. I would like to talk about Charles. Charles was a person that was suffering from depression and cannabis use disorder. I met Charles when he was 21 years old. He was a McGill student. He came to the emergency of the Montreal General Hospital with his girlfriend. Charles was presenting suicidal ideation with a severe symptom of depression, like insomnia, anxiety, no appetite, pessimism, lack of concentration. The things that struck me from Charles was the absence of depression in the past, no family history of depression or mental health issues. He came from a very lovely family. He was born in Paris. His father was a doctor working for a pharma company. His mother also was a doctor working as a part-time. One young sister. The only trauma in Charles' life was when he was 15 years old. He lost his best friend for a rare cancer. At this time, he reacted with a lot of resilience. The parents asked him to search for psychological help. Only in this case, he just tried once cannabis, just a couple of times. Then at 18, he moved to Montreal to study engineer, and during a period of stress, he started to consume cannabis. First once a week, then twice a week, 3 times a week, every day, and slowly start to develop this symptom of depression until suicidal ideation. It was at this point that his girlfriend brought him to the emergency. Now I will talk about Charles also at the end of my talk. The objective today is preclinical, to demonstrate a preclinical study how cannabis can affect the brain after acute and chronic consumption in adolescence and in adulthood. Then I will show some epidemiological clinical study demonstrating the link between depression and cannabis, and then at the end, the role of the endocannabinoid system in depression. So the first question that we ask in my laboratory is, cannabis is an antidepressant or is a depressogenic? And the first question is, why people like so much cannabis? So there was this scientist in UK that studied for many years cannabis. Now he passed away, and he described the high of cannabis in a very sophisticated manner. I would like to read. So the high produced by cannabis is a complex experience characterized by a quickening of mental association, sharpened sense of humor, sometimes described as a state of fatuous euphoria. The user feels relaxed, calm, talkative, in a dreamlike state, and disconnected from real world. So this is why people like cannabis, because you laugh, you are happy with cannabis. It's easy to have a social contact when you go to a party. So cannabis is a strong attraction, especially for young people. Indeed, there is this paper published in 2020. It seems that 64% of people report relief of depressive symptoms after cannabis. Only 20% report increased depression. This other study that was published by a former student of mine, Ryan McLaughlin and Carrie Cutler, also report that medical cannabis in acute alleviate depression. Indeed, in both women and men, after joint, there is a decrease in the rating of depression. So, but the question is, what is the neurobiological mechanism of action of cannabis in mood control? What is the mechanism of action of THC, the synthetic CB1 and CBD? And what is the long-term effect of THC consumption in adolescent laboratory animals? So, just for people that are not familiar with cannabis, cannabis contains more than 100 ingredients, but the principal are the THC, that is the bad guy because it produces high, it produces also dependence and addiction, and the good guy, that is the CBD or cannabidiol, that mostly act in 5-HT1A receptor and vanilloid receptor. And then for research, but also in the black market, you can find the WIN 55212, that is a synthetic agonist receptor CB1. So the THC in the brain binds a receptor called CB1 receptor, but also CB2 receptor. But the main one in the brain is a CB1 receptor. So why in the brain we have a CB1 receptor? Because actually our brain is able to produce its own cannabis. The own cannabis of the brain are called endogenous cannabinoids. Two of them are the anandamide, A, and the 2-arachidonyl glycerol, 2-AG. They are small lipids. They are small lipids that are in the postsynaptic membrane. In case of stress, in case of inflammation on demand, these lipids are released and then act at the level, at the presynaptic level, in the CB1 receptor. So this is why we have a CB1 in our brain. But the CB1 receptor is also co-localized with the serotonin neurons, especially with the serotonin neurons of the dorsal raphe. So the first experiment done by my former student, Francis Bambico, published in 2007, was to test if the cannabinoid WIN 55212 has an effect on serotonin firing activity. And what Francis found that at low doses, the CB1 agonist increased the serotonin via a CB1 mechanism. In fact, it was blocked by rimonabant, that is a CB1 antagonist, but not by capsaicin. However, at higher doses, the serotonin decreased. And this decrease was not CB1 mediated, but mediated by vanilloid. So what we see here that the CB1 has a double effect. At low doses, there is an increase of serotonin, but higher doses, there is a decrease. Very interesting, this effect was parallel also by behavior. At low doses, the WIN has an antidepressant effect because it increases swimming by decreasing immobility. But at high-risk doses, this antidepressant effect disappeared. And the antidepressant effect was mediated by CB1 since it was blocked by rimonabant. Then we ask how the CB1 can control the dorsal raphe. And we ask if it was the prefrontal cortex to control the effect of CB1 in the dorsal raphe. It was since 2007 when the optogenetic didn't exist. So Francis hypothesized this experiment very well done. He did the transaction here, the complete transaction of the prefrontal cortex, but also the transaction of the medial prefrontal cortex and lateral prefrontal cortex. So what he found, when you have the complete transaction of the prefrontal cortex or medial prefrontal cortex, you don't see anymore the effect of WIN on serotonin. But when you cut the lateral, you still see the effect. So it means that effect of CB1 agonist over the dorsal raphe is mediated by the medial prefrontal cortex. Then Francis also tested the THC on serotonin neurons. And with the THC, we have also more complex responses, because some neurons increase the serotonin firing activity, but some neurons were decreased. So you can see here that a population of neurons of dorsal raphe increase after with acute excitation after THC, and others show an acute inhibition. This difference that we saw between the WIN and the THC may be linked to the fact that the THC is a partial agonist at the level of CB1. But then also Francis tested the THC in a Purcell test, forced swim test. And what he found was very interesting, because after a single administration of THC, he didn't see any antidepressant effect. But after repeated, after 4 administration, each one administration a day, we saw an antidepressant effect similar to citalopram. It's very interesting because also cannabis smokers say the first time they don't feel anything, but after the second, third joint, you can start to feel the antidepressant effect. Then we test also the cannabidiol. Danilo De Gregorio published this study in 2019. A cannabidiol is still different from THC, the WIN. Cannabidiol actually acts like an SSRI because in acute decrease the serotonin firing activity, and this was blocked by the way that a 5-HT1A antagonist, but was not blocked by the CB1. And here you can see that the CBD decreased the serotonin firing activity via a 5-HT1A receptor. Then we administered also cannabidiol for 7 days. And after 7 days, cannabidiol, also similar as SSRI, increased the firing of serotonin. And there was also a mechanism of 5-HT1A desensitization. Then we test if cannabidiol has antidepressant-like effect, but we didn't see any effect in acute. We didn't see any effect after repeated, but when we used high doses of cannabidiol, about 30 milligram kilo, we were able to see a decrease in immobility. However, the most significant data with the CBD were mostly in pain. We were able to see with these low doses of CBD, 5 milligram kilo a day for 7 days, an effect in neuropathic pain. Just to summarize until here the acute effect of cannabis, We know that the CB1, the synthetic WIN, increase at low doses the serotonin firing and decrease the firing at high doses, and an antidepressant-like effect at low doses. THC has a mixed effect on serotonin. It is antidepressant at low doses, but after repeated administration. And the CBD decreases the serotonin firing activity and then restores serotonin after repeated administration, and has antidepressant effect only at high doses and has anti-pain effect. Now, let's go next. So we saw that in acute administration, cannabis has an antidepressant effect. The problem is what happens if you consume cannabis in long term for many days, many years. So, and we ask what happened to adolescents that for many years consume cannabis. As you know, cannabis is mostly consumed by adolescents or young adults. And now, more recently, in particular in Canada, with the legalization, we have a new phenomenon of cannabis consumer also in adulthood and in elderly. As you know, the brain develops until the age of 25 years. During adolescence, we have still a refinement of the brain with the new myelinization, synaptic refinement, receptor that change, the metabolism of the brain that change. It's clear if we introduce a drug of abuse during adolescence, there is a change in brain development. So we know very well the study done by Reed, published in 2004, that the brain develops from the back to the front, and the frontal cortex is the last part of the brain that develops until age 25, even later. So there are now a lot of studies, more than 30 brain imaging studies, that have demonstrated the consumption of cannabis has effect in the neurodevelopment on the brain. So in our laboratory, to answer a little bit this question, we did this complex experiment. We exposed some adolescent rats to THC during adolescence from 30-50, but also some adults from age 50-70, we exposed to the same dose of the THC. Then both groups have a period of washout, and then we test as adults in electrophysiology and behavior. So we ask how you feel today. So what we found that adolescents exposed to cannabis but not adult have had some symptoms of depression. In particular, the latency to the first episode of immobility was much shorter in rats exposed during adolescence than in adult. More interesting was the sucrose test. The sucrose test again showed that adolescents exposed to cannabis in adolescence, then in adulthood have had a decrease sucrose preference, that is a symptom of anhedonia. And we were very happy of this data because it seems that the depression in humans induced by cannabis is more a depression characterized by anhedonia, a motivational syndrome, plus than just sadness. Then we test also anxiety, elevate plus MAIDs, and here very interesting, we found anxiety in both group of adolescents but also adult. So for the open arm time as well for the entries in the open arm. Then again, we come back to serotonin, norepinephrine. We know that CB1 is located not only in dorsal raphe, but also in the locus ceruleus of where there are the noradrenergic neurons. And what we found very interesting that both in adolescent and also in adult, the serotonin firing activity was decreased after long-term consumption of cannabis. Not only, the serotonin neurons is characterized by a regularity. It's a very regular neurons that really fires ta, 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 ta. And after THC, the neurons lost this regularity. We tested also the norepinephrine. Even if there was a trend in increase of norepinephrine in rats during adolescence, was not significant. It was less present in adulthood. So this means that cannabis has almost a specific effect on serotoninergic system. So then other colleagues also at the same time were studying the same problem. Dr. Rubino e Parolaro in Italy also published similar results. They see, for example, a more pronounced effect in depression, especially in female rats. They also observe a decrease of social behavior after exposure to cannabis in adolescents. Very interesting, they found a decrease in CB1 density and an increase in CB1 G protein coupling. Very interesting, they found that after cannabis exposure, there was a decrease of the endocannabinoid anandamide, but not 2-AG. They found also significant effect in cognitive function in the radial maze, especially in female, as well as in the object novel recognition, especially also here in female. Okay, but we talk a lot about serotonin, noradrenaline, but we have not to forget about the effect of cannabis on dopamine. In particular, I would like to cite this very important paper that was published in 1997 by Di Chiara, and with microdialysis, he demonstrated that the THC increase in the prefrontal cortex the dopamine, similar to heroin, and this effect was blocked by an opioid receptor. And then a lot of groups also replicated this data with other drug of abuse, for example, also cocaine, amphetamine, and they found this common feature, this increase of dopamine in the nucleus accumbens. More important, during the withdrawal from cannabis, also yesterday, Kubs also show the same results from the same group with alcohol. We know that after withdrawal of alcohol, cannabis, heroin, cocaine, we have a dramatic decrease of dopamine firing neuron in the VTA. And this is also a feature of withdrawal of cannabis and other substance of abuse. Very interesting, this deficit in dopamine release was also replicated by Dr. Abid Dargam in humans with PET imaging. So now conclusion one. In animal studies, what we can say, that acute cannabis consumption activated the serotonin firing activity, long-term consumption of cannabis during adolescence and adulthood induced a decrease in serotonin spontaneous firing activity. These electrophysiological hallmarks are paralleled by behavioral impairment, mostly anhedonia in adolescents. Cannabis produces impairment at the level of cognition and social behavior. Females seems are more sensitive to depression. Acute cannabis consumption increases the release of dopamine in the nucleus accumbens, and cannabis withdrawal induces a decrease in the VTA dopamine firing. Now pass to my second part. So since we are not happy about the research, we decided to go and to study also humans. So what happens in humans that for many years consume cannabis? Does cannabis also induce depression in people that consume cannabis for many years? There was this very interesting paper published in 2002 by a group in Australia. It was the first paper demonstrated that cannabis increased later depression by 1.9 to 300%. And this increase in depression was in teenager girls. There was also another study published in Lancet, also where they found an increase in depression in the general population that use cannabis. And another one was also published in Canada in 2013. But our question, our laboratory, was more specific. We want to understand if adolescents that start early to consume cannabis, even without a premorbid depression, should eventually develop depression later. And we want to know also about anxiety, about suicide, about suicidal behavior. So we decide I'm not an epidemiologist, but with the help of epidemiologists in our university, Nancy Mayo, she helped us to do this meta-analysis. So we went to look all the papers that consider population between 13 and 18 that were consuming cannabis, and we asked what happened at the age of 21-30. But we look only for papers that adjusted for premorbid depression, anxiety, and other main factors. So we want to see the children that start cannabis just for fun, not start cannabis as a self-medication. So we analyzed more than 5,000 papers. Finally, we arrive at 35 studies, including qualitative synthesis, 11 studies, including in quantitative synthesis. So what we found that actually cannabis increased the risk of depression by 37%. Increased also anxiety by 18%, but we found a lot of heterogeneity in this data, so we couldn't take the data as absolute. But the most interesting, also surprising data, that cannabis increased the risk of suicidal ideation by 50%, and the risk also of suicide attempt by 300%. But again, this data has a lot of variability, so we should not take very seriously. So why these results are important? Because these results say are controlled for premorbid depression and found that even if this effect size is modest, since the use of cannabis is common, it means that a lot of depression in our countries are created by cannabis. It's a little bit like smoking cigarette. If in a country only 3 people smoke cigarette, the number of lung cancer is low. But if a lot of people smoke cigarette, we have a lot of lung cancer. And with the epidemiologists, we also study the population attributable risk. That is a calculation that you do calculating how many adolescents smoke cannabis in your country, how among adolescents are present in your country. And with them, we found that in Canada, we could avoid 30,000 depression a year, and in the United States, about 250,000 depression a year. So these are data very important. The limitation, of course, is meta-analysis that are association on causality. We have a heterogeneous method to detect depression and no information about the quantity of cannabis. So the big satisfaction was after we published this data in JAMA Psychiatry, A lot of studies replicated the same data in a Finnish court, another study by Nora Volkov in the United States. This was in South America and in other countries, and all were able to replicate the data that we found in this meta-analysis. Not only in always McGill University, another group led by Dr. Geoffrey, using the Mendelian randomization, also were able to replicate our data on suicide. They control for genetic factor, and they even control for the co-abuse with alcohol and smoking. And they found that only cannabis, not alcohol, not smoking, increased the risk of suicidal attempt. Also, Dr. Arier De Witt, they did a very nice study testing THC in adolescent and adult with the EEG, and they found that adolescents have an increased power in all the different waves of the EEG, and this demonstrated that adolescents are much sensitive to cannabis than adults. So this was very funny. After that, I published this meta-analysis. This group from England, they contact me by mail, say, why, Dr. Gobbi, you didn't include our study? But their study was just 2 months before our study was published. But this is a very interesting study because they asked the same question, and they were able also to see what is the cutoff when cannabis is critical for developing depression. It seems that before age of 27, you are more risk to develop later depression if you consume cannabis. But after the age of 27, the risk decreases. There is also a protective factor of cannabis over depression. So it's a very interesting study. Conclusion, too, so cannabis may have an antidepressant effect in short term, but after long-term consumption, especially in adolescents, induces depression. A meta-analysis studies indicate that cannabis during adolescence increases the risk of developing depression, suicidal behavior in young adulthood, even when adjusted for premorbid depression, anxiety, gender, socioeconomic status, cigarette, alcohol, inhalants, etc. But now come back to Charles. Okay. Now, Charles was this student that found himself with depression and the cannabis use disorder. So what we do when a patient suffers from cannabis consumption and depression? First of all, it's important to approach the patients to understand why somebody starts to consume cannabis. Ask also how much do you consume, which kind of cannabis, how often, what is the concentration level. Now in Canada, you can buy in the shop a joint with 40% of THC, 50%, 80% of vaping. Just to put you in the context, the cannabis of consumed in the past was about 3%, was about 10% maximum. Today, instead, we found a very high concentration. So the cannabis of Bob Marley was 3% of THC. Now we have 40% of THC. And then we have to ask also about withdrawal symptoms. How much is too much? So until now, we don't have a study that really say how much is too much. However, the epidemiological study suggests that the daily consumption of cannabis increases the risk of depression, also psychosis. But also the weekly consumption of cannabis increases also the risk of mental health. And then, of course, we still lack recent data about the high concentration of THC in depression. There is always the group in UK that now publish several papers about the high concentration of THC in psychosis and schizophrenia, but we still don't know the effect of a high THC concentration in depression. And then, of course, in Canada, also in Colorado, some places in the United States, we have these edibles that contain 10 milligrams for each cookie or each bonbon, etc. So the symptoms of withdrawal are also very complex. This is another problem when we treat depression in cannabis, because the cannabis withdrawal is not like alcohol, that the person the day after that does not consume alcohol start to shaking, has a headache, or the person that smoke a cigarette after 20 minutes feel the need to start another cigarette. Cannabis, the withdrawal of cannabis can appear after 1 week or after 2 weeks, because the THC is a lipid, so goes in our body fat and can stay there for many days. So very often both doctors and also patients have difficulty to recognize the symptom of cannabis. The symptoms are irritability, anxiety, depression, feeling restless, having trouble sleeping at night, feeling tired, and change in appetite. So the problem of withdrawal is that very often patients don't distinguish the symptom of withdrawal from the real mental symptoms. Unfortunately, the treatment for depression associated to cannabis is very scant. We know that when a patient suffers from depression and cannabis use disorder, has more risk to develop a treatment-resistant depression, a depression that does not respond to the common SSRI or other antidepressant. However, the good thing is if a patient stops cannabis, also the treatment-resistant depression improves. So, again, we don't have a standardized treatment to treat depression associated to cannabis. Still, we need really more research. So we know that motivational therapy works, cognitive behavioral therapy works, and there are some small trials using antiepileptic drugs as gabapentin, sodium valproate, lithium, lamotrigine, topiramate, but also bupropion and buspar. But these are very small clinical trials. We still need more research and a consensus how to treat the cannabis depression associated to cannabis. So, coming back to Charles, after a few days spent at the emergency, was dismissed and followed as outpatients. He was treated with antidepressant, with the fluvoxamine 100 milligram, and then started a motivational therapy, helping him to quit cannabis. Cannabis was decreased slowly, and gabapentin plus a benzo at night were prescribed for the withdrawal of symptoms. And then, of course, he received psychotherapy. But believe me, to help a patient to recover from depression after cannabis is a long journey. Sometimes it takes 1 year or 2 years. Now I'm going to my last question, and we have still 15 minutes. What is the role of endocannabinoid system in depression? So, again, our endocannabinoid system, as I told, is formed by endogenous cannabinoids that are released postsynaptically to the CB1 receptor. And in 2005, we start a research in collaboration with the University of California using the URB 597. URB 517 was a small molecular entity that blocked the FH enzyme, the enzyme that degrades the endocannabinoids. So by blocking the degradation of endocannabinoids, you can increase the endogenous endocannabinoids. And we demonstrate in PNIS now in 2005 that the blockage of the degradation of endocannabinoids with the URB 597 after acute subchronic treatment has an antidepressant-like effect. This effect was similar to the desipramine. It was blocked by rimonabant. We also saw that 597 increase in a time-dependent manner the serotonin firing activity. Here you can see the increase in serotonin firing activity after acute and repeated treatment. And we find also an increase of serotonin at the level of prefrontal cortex, but not hippocampus. Also, Francis Bambico also tested the FH knockout mice. He found also in FH knockout mice an increase in serotonin activity and a phenotype as antidepressant. So since then, several FAH inhibitors were developed by different industry. A lot of them enter in phase 1, in phase 2 for PTSD, pain, and depression. Unfortunately, in January 2016, during a phase 1, one patient died. It was a man with 4 children. So it was really a tragedy for people working in the field because, of course, when you have a death in phase 1, you stop all the research. But this death was caused by a high doses that was administered to this man in massive dose, while the FH inhibitors work at very, very low doses. However, in spite of this insuccess, Dr. Deepak Souza in 2018 published this very nice, elegant studies. It's a double-blind, placebo-controlled study to block the cannabis withdrawal in people with cannabis use disorder. Very elegant study demonstrated that FH inhibitor can block the withdrawal. And very interesting, the most important effect of the FH inhibitor was in symptom of depression of people with chronic use of cannabis. But then we were still not very happy. So after many years of working in animals, we decided to see the role of endocannabinoids in people with depression. So with Dr. Komai, we just published in January this study called Dysfunction in Endocannabinoid, Pamitol, Etalolamide, and degradation of tryptophan into kynurenine in individuals with depressive symptoms. Practically, at McGill, we collect 33 people without depression, healthy volunteer, and 49 people with depression. And we decided to study 2 things in these people. Of course, the endogenous endocannabinoid as anandamide, 2-AG, OAI, other endocannabinoids, but also to study the tryptophan pathways, serotonin, kynurenine. As you know, in people with in normal people, the tryptophan normally is then metabolized in serotonin, melatonin, and only in minimal part become kynurenine. But has been demonstrated by our group, by Komai, by several groups, that in people with depression, there is a deviation of tryptophan through kynurenine. So the relationship between kynurenine and tryptophan is higher than serotonin tryptophan. So doing a principal component analysis, we found this very interesting data. So people with depression had an increase of endocannabinoid as OAA, also PEA, AEA, But most important, also an increase on kynurenine-tryptophan ratio. So as if people with depression have this ensemble of biomarkers. On one hand, there is this increase in endocannabinoids, probably is a response to inflammation, parallel by this also increase in kynurenine-tryptophan ratio. Instead, the healthy volunteer, you see have tryptophan and serotonin. So my conclusion in a preclinical study suggests that FH inhibition may represent a pharmacological target for treating cannabis use disorder and depression, but we need more safe pharmacology. And the endocannabinoid system, like also the tryptophan, kynurenine, serotonin, can represent a biomarker for depression, being parallel to the degradation of tryptophan to kynurenine. Finally, take-home message. We can say that basic and clinical research confirm that long-term cannabis consumption during adolescence is a risk for depression, even in absence of premorbid conditions. Cannabinoid interacts with brain areas involved in the regulation of mood, such as serotonin and the endocannabinoid system. And more clinical studies are needed regarding the treatment of depression associated to cannabis use disorder. Just before this lecture, I went to see again a PubMed if there were new studies about the treatment of depression associated to cannabis, but still we need really more research and more clinical trial. So the endocannabinoid system may be a biomarker for depression as well as a therapeutic target. Thank you again, especially to Dr. Bambico, Danilo De Gregorio, Stefano Comai, all these people that during this year have collaborated in create more knowledge about the risk of cannabis use and major depression. Thank you very much for your attention.
Thank you, Professor Gobbi, for this very insightful presentation, really taking the topic from the lab to the clinic and the important impact for our patients. So actually, we do have time for questions. So if people have questions, please go to the microphone, identify yourself.
Thank you. My name is Daniele Pagliaro, University Hospital of Udine, Italy. Thank you for your brilliant presentation, Professor Gobbi. Well, I was quite surprised looking at increased endocannabinoid serum levels, for example, anandamide and especially palmitoyl etanolamide in depression, while they are well known for being anti-inflammatory molecules. Perhaps, is there an explanation of this increased serum level of endocannabinoids? For example, could it be since actually an increase bound to an endogenous attempt to give relief to the depressive symptoms?
Yes. We actually, the reviewer asked us to control if it was due to medication or not. Probably, as you say, is a reaction of the body and the brain to fight depression. So it's a kind of inflammatory response. So, yeah.
Thank you.
Thank you.
Please, back there.
Thank you for your talk. Peter Jenkins is my name. I'm from Melbourne, Australia. What would be your advice to psychiatrists working in countries where cannabis is not yet legal?
Is not get label, you mean?
It is not yet legal.
It's not yet legal, okay. So, yeah, a lot of people ask me about legalization, not legalization. Me, I think at this point is not a problem, legalization or not. The problem is to have a good law. So to be regulated in a safe manner, in a reasonable manner. Now we know a lot how cannabis works, how cannabis can be dangerous. So it means create a good law. So, for example, regulate the concentration of THC, or create more cannabis with high content of CBD instead of THC, or regulate the age of the use of cannabis. So there are so many things that we can do for our population. For example, last year I was invited at Addiction in Lisbon. So people talk a lot about Uruguay. Uruguay, that was the first country in the world to legalize cannabis. But actually, it's very intelligent because in Uruguay, only pharmacists can sell cannabis, and they put the maximum of 10% of THC. So there are different strategies to legalize cannabis in an intelligent manner. I hope I have answered your question.
Yeah, so in other words, be careful. Don't just do it anyway.
Yeah.
Gentleman in the front, please. You.
Satoshi Hayama, Kyoto University. Thank you for your presentation. Cannabis-induced cortical atrophy. Cannabis-induced?
Cortical atrophy.
Cortical atrophy.
Yes.
Okay, this is a matter of debate. Okay, somebody say yes, somebody say only if associated to alcohol or other drug of abuse.
Thank you. Did you do autopsy about cannabis poisoning?
Autopsy?
Autopsy, yes, autopsy. Pathological autopsy.
Good question. I don't know. Very interesting.
So, for example, people who would have died by suicide who were chronic users of...
I know, at the Douglas and McGill, we have a brain bank with people that commit a suicide. So a lot of studies were done in the brain. And I think in a lot of people that commit suicide, they find as 80% of cannabis a strong association. Strong. There are 2 or 3 studies where they found a strong association.
Okay. In Japan, Matsusawa Hospital in Tokyo have many autopsy pathological experience, but now we don't do autopsy about, for example, drug dyskinesia and this poisoning. Thank you.
This is very, very important. But there are 2 or 3 papers with autopsy where the rate of cannabis is incredibly high. But some people criticize this study because it's a kind of a retrospective study, not prospective. But,
Please, on the side, yes.
Yes. Well, hello, I'm Ko Smit. I'm an addiction psychiatrist from Holland. Where we had our problems with the cannabis, and perhaps we are in Holland. We have trained the cannabis to get up to 40% of THC. So, do you think it's wise, because all over Europe, all over the world, they permit people to smoke cannabis freely, and do you think it's wise not to set a limit to the amount of THC, because of course you get more people who become psychotic. There is what's the use in not setting a limit to the amount of THC?
Yeah, we as a countries, of course, we risk a lot not to put a limit. In Canada, for example, before the legalization, there was a group of doctors that suggest the government to put the limit of 10%. But then the pressure of companies obliged the government not to put a cutoff. And now we see in Canada the amount of visit to the emergency due to the high concentration of cannabis. Of course, we have more psychosis, more psychotic crisis. This is a big health issue.
Mm-hmm.
I don't know. What do you think?
Well, I think we should. Well, a lot of people just want the cannabinoid effect to feel yes, just satisfied and cool down, and so and some of them, of course, want to get high.
Yeah.
So, well, that's something you have to put some motivational therapy into. But I don't think there's any use in the high amount of THC, and of course, cannabis gives you cancer. So I agree, and I would like to thank you again for the very, very clear statements you've made, and things are becoming a lot clearer in my mind.
Yeah. And then all the epidemiological study that I present were done. Epidemiological study are long, so were done 10, 20 years ago when cannabis was still 10%. Now we have no data about cannabis today at 40%. But very soon we will start to see the huge effect in a population. And then, more cannabis, higher THC, more high, but also more risk of becoming dependent, tolerant. So other consequences.
Thank you very much
thank you very
for
much.
your opinion. And then we're over time, but we'll take one quick question, please.
Thank you. Thank you for the excellent talk. I'm Chang Luo from Fudan University. I'm a researcher. And I would like to ask, in your data you presented that the earlier exposure to cannabis seems to have more consequences. So is there any evidence on prenatal exposure to cannabis on consequences on health?
Sorry, pre-adolescent.
Prenatal exposure to cannabis.
Prenatal exposure. Yes, in New York there is a Jasmine Hard that did a lot of study in prenatal. It seems the most important effects are in cognition. So it means that women that smoke cannabis during pregnancy, they have more risk to have children with ADHD or learning disabilities. I don't know if I answered your question.
Is there any evidence on some brain changes, like the brain structural function?
Yes. She did a lot of study also on dopamine changes, structural NMDA changes, if you see, she's a specialized, look at the literature of Jasmine Hart, Hurdt.
Okay, thank you.
She did a lot of studies on this,
Thank you very much again, Professor Gobbi, for this insightful presentation, and we look forward to further studies from your group. Thank you for attending.